So I'm a urogynecologist, so the patients who I see are only women, and obviously you're a urologist, so you have the advantage of seeing both men and women. So I'm kind of curious from your perspective, or if you have insight into like the male patients' perspectives on some of the issues that women bring up to me that they're having issues with. So one huge thing is like libido mismatch. And I think like, we obviously trying to not pathologize libido, and it's only an issue if it causes personal distress. And I think a lot of time for these women, it wouldn't cause them distress if they weren't partnered, but I see so many women who are like, oh my gosh, I'm gonna lose my, male partner if they're in a heterosexual relationship over this. So I'm just curious, what you hear from the male side and what advice you give to women in that situation.
Yeah, so I think for women and men, so from the men's perspective, they'll often, if they're not having issues either with libido or with erectile dysfunction, right, they'll often say, I'll ask them, are you still having erections? Well, yes, but we're not really having sex anymore because my wife's really not that interested. Or, when we have sex, she has pain. And actually we'll counsel them that, she needs to go and see someone, and because that's an important part of their intimate relationship, right? So if he's coming to me because he says, I don't have the same libido, right? So we're going to talk about his testosterone levels. Or if he's saying he's having issues with erections. And, I think both men and women, either way, get embarrassed by any sexual dysfunction that they have. Right. And they don't want to disappoint their partner, right? And that also in itself creates guilt and stress on the relationship, which then starts to make having sex a chore, right, instead of something they actually want to do. So I think you have to be willing to counsel both the man and the woman. For women and for men too, it is actually very hormonal, which I know you're going to talk a little bit about. I mean, is she on estrogen? Maybe she needs some DHEA. Maybe she actually needs some testosterone, right? And then for men, the same thing. Is the problem just the erections and they still have the sex drive? I think a lot of patients don't understand that for men, the testosterone is the sex drive. And it can have something to do with erections, but you can, give a pill, an injection, you even use a penile pump to get the erection, but they won't maintain the erection unless they actually have the drive.
So that is so interesting to me because I didn't know, like for women, I know our most, important sex organ is our brain, but which makes things so complex and multifactorial. And that's why before I even talk to them about, hormones and some of these FDA-approved pills that we can talk about in a little bit, I always try to get into the conversation that you're talking about, the interpersonal things, or even just the stuff about body image, stress, sleep, all the other factors that go into it first. So it's interesting to know that men are not as unifaceted as I was thinking that they might.
No, not at all. And they're very in their heads about everything, just like women are, right?
Okay.
So I think that you have to address both things with men, and then you have to address their partner too, because they are getting, and either partner, if one wants to have sex and one doesn't, and one has drive and one doesn't, but that's going to lead to more stress.
Right, absolutely.
So can we talk about what the factors are in that drive, which are what you guys have already talked about, but go over it again, is like hormones, but also like physical pleasure or pain. So can each of you kind of talk about how that affects women and or men, if you want to, Dr. Linehan, but like I know that all of this is an important part of it, right? Like there's brain, there's physical, and there's hormones. So who wants to start? Lauren.
You haven't heard Lauren's
the physical part.
I'll start from the physical side. So there's arousal, which is like your physiological response where your body's getting ready for intimacy. So it's like increased blood flow to the genitals, increased heart rate. And then there's desire, which is the want to do something with that, so they'll want to engage in sexual activity. And so there's two main types of desire. One's called spontaneous desire. So it would be like you see a racy photo, you get a racy text, you're excited to see a partner later. And so that's the spontaneous desire that just comes up within you. And then the other type of desire is called responsive desire. So that's arousal or desire in response to kind of beginning an intimate activity or an engagement with another or with self. So most men experience spontaneous desire. And both genders can have both, but it's more common for men to have spontaneous desire, whereas women, it's more common to have responsive desire. So you might not have this like spontaneous arousal, but a common recommendation is like, you know, like I recommended like a naked Tuesday where you and your partner like get into bed, no clothes on, and just kind of see what happens. And a lot of times the desire can come once you've started the activity. So that's what I'll answer for now.
Good. So I think for women, you know, is it comfortable, you know, to have penetration? Is there vaginal lubrication? And then is there desire? So a lot of times our vaginal lubrication does come from our desire, but also it doesn't, even if you have desire, you still may not getting lubricated enough to have sex. So I think recognizing if penetration is painful, why? Is it because I'm dry? Or is it just hurts? Or is there something anatomical? Like, is my bladder falling down? Am I rectum pooching up inside my vagina?
Who answers that question?
Normally, it's either the urologist, the gynecologist, or the urogynecologist, right?
Okay.
So is there something anatomical going on that's keeping me from having sex? So I don't know if you want to address the hormonal perspective from that side.
Yeah, for sure. So yeah, as far as, actually I'm going to back up a little bit. So I think in answer to your question, like zooming out, I think libido is basically, if we have a decreased libido, if we're not wanting to have sex, that means there's something about sex that we're not enjoying. So is that physical? Is it pain? Is it, you know, our own body image that we've gained weight and we don't feel comfortable getting naked? Is it we're angry at our partner and we don't want to have sex? Is it something that's like societal pressures, that the things that arouse us are societally, you know, frowned upon, so we're embarrassed to tell anybody like that's what we want to do. So there's all of those kinds of things which are, you know, I can prescribe a pill, I can prescribe a hormone, but it's not going to fix, you know, the fact that your partner left dishes in the sink and you're mad at him, and you know you can rub stuff on your clitoris all day long, but it's not going to like fix that. So I think we have to really like start with those kind of issues first, and so a lot of it might be couples therapy or personal therapy, and if it's not those issues, then the next thing I look for is if the patient is on an SSRI, because SSRIs can suppress libido. Serotonin can suppress libido. So if a patient is on an SSRI, we either switch them to something called Wellbutrin, or we add the Wellbutrin on top of the SSRI. And then if everything is just amazing and the patient, you know, the relationship's amazing, their sense of self is amazing, everything is fantastic, they're not on an SSRI, that's when we start looking for other things, like you said, pain. And for postmenopausal women, yeah, pain is the number one reason for decreased libido. So that's because as estrogen levels decline, the vagina just doesn't get lubricated, right? So then if something's painful, you're not going to want to do it. So yeah, how do we replace that? Whether someone's on systemic hormone therapy or not, I think every woman should be on vaginal estrogen therapy. There's really no contraindications to it, and you might know more about this, but even active breast cancer patients, their oncologists are almost always fine with them using vaginal estrogen because it's not getting absorbed into the bloodstream in any significant amount. And it really helps with the dryness. But there's also over-the-counter things, right? There's moisturizers for the dryness just when you're not having sex, and then there's lubricants, which we can get into the different types of lubricants. But then vaginal estrogen, I don't know how deep of a dive anybody wants to hear about the different types of vaginal estrogen.
Well,
but
let's see. If there's questions, please put them in the chat box. But I think, the interesting thing is all three of you gave different places to go. So if you're having difficulties in your sexual relationship, and do you start with psychotherapy because you're having marital problems? Do you start with pelvic floor physical therapy? Do you start with the urologist, urogynecologist? Do you start with hormones? Where do you start? Your primary care doctor? I want an answer from each of you. None of you are getting off on this.
So I would say first, no one wants to have sex that they don't like. So part of it is getting clear on what type of sex you want to have. It's a lot easier to have sex that you are excited about if you like it. So there's two things. One, the barriers usually, so this is from Emily Nagoski. She's a PhD and she wrote this book, Come As You Are, but most people, you generally have sexual accelerators, which are things that turn you on, and sexual brakes that turn you off. So things that turn you on, if someone smells good, if they look good, if you have had sexual encounters with them in the past and they were great. Sexual breaks are like what Dr. Lane was saying. So you're tired, you're stressed, there's too many chores to do, you just had a baby, there's pain. So the first recommendation would be you can write a list of your sexual accelerators and your sexual breaks, and try to manage the sexual breaks as much as you can. There's a saying, for at least new moms, chore play is when their partner does all the chores and then they feel really good and excited. So that would be one simple intervention. Another one, you can Google this, but it's called a yes, no, maybe list. And it goes through, some of them are very long and very in-depth, but it goes through many different types of sexual activity, touch, oral, penetrative, and you go through, you and your partner can do it, and you write down if you're interested or not interested. So yes, no, and then maybe. If it's a maybe, you write why it's a maybe. So I've never done it before, or I'm worried it'll hurt, and then you guys can talk about it. So I think sexual communication, knowing what gets you going, and starting there, it's a free intervention. You can see if you can kind of sort it out, and then that might draw you to the next thing, okay, it's pain, let me see the doctor, right? Erectile dysfunction, let me see the doctor. So I think those would be my places to start, because it'll answer some questions. And I've given this to patients who have been with partners for a long time, and they get excited. They're we've never talked about. People in general don't really talk about sex or finances, and so I think it's a good way to open up the conversation for both partners.
It's way more fun to talk about sex and finances, by the way. I would much rather talk about that.
So, Lauren, before you move on, you said two things: see the doctor. See the doctor. When would you see a pelvic floor physical therapist?
So usually, I would say it depends what's going on. Because there are more, there's, as Dr. Linehan and Dr. Lane have mentioned, there's multiple different interventions that can be recommended. So pelvic floor PT is good if you have pain, also erectile dysfunction, and strengthening the pelvic floor muscles, which are what contract with orgasm. So, but because there can be a hormonal imbalance that kind of contributes to it also, I would say see the physician, because they can always refer to us, So
I'll answer it from the other perspective. I refer to pelvic floor PT when patients are having too much pain, pain with sex that's not attributable to just dryness, or anorgasmia, for patients who are, as you said, not having orgasms and it's a blood flow issue. There's physical, I recommend that they buy, sorry?
Depending on your symptoms.
It's symptom related.
It's symptom,
exactly.
yeah. If you have pain, erectile dysfunction, okay. So sexual function is there. It's the biopsychosocial model. So there's the biology. Can you biologically have sex? Can you lubrication, hormones? Do you have enough blood flow down there? How's your sensation? That's the biological model. There's a psychological model. Shame, what our upbringing taught us, our doubts, and then there's and then the social one is like how you feel about your partner. So I think if it falls into the fit, like the biological part, and that seems like a barrier, then I would say tell a healthcare provider. If you also, I dream of a world where you can talk to your healthcare provider about, even if it is an interpersonal relationship, because we all have referral sources for people who are sex therapists. So I would say it's a good landing point to tell your healthcare provider, because they can kind of discern where you might need to go next.
So, I mean, for me, I always start with all the normal questions, like, do you masturbate? So for men and women, it's different, but the questions are going to help me sort out what your main problem is. So for men, it's like, are you able to get an erection? Do you get morning erections? Do you get erections when you masturbate, but then you can't get erections when you're trying to have sex? Like, these are all different questions that are going to help me weed out how I can help them. Or if it's libido, or if it's a partner issue, or if it's something that's going on between the couple, right? And, like I said, sometimes she's not interested in sex, sometimes he's not interested in sex. Sometimes the women comes to me and they say, but my partner can't get erections, right? Yeah. So, but there are other things you can do, like oral sex and different ways of penetration that might be just as exciting. And I do know couples that will do that. And I think, for women, it's the same questions as, does sex hurt? Do you have the drive to have sex? Do you like your partner, right? And then with the estrogen, I mean, don't forget the fact that the vaginal estrogen, I mean, not only does it create lubrication, but it increases the blood flow. It helps the nerves. It plumps up the tissues in there. It rebuilds the collagen. So it does a lot of things just besides the lubrication. And of course, obviously, the estrogen also gives you a little kick in your sex drive.
What are the different ways to get vaginal estrogen, local?
So there's creams, there's tablets, and there's a ring that you can place in the vagina, and it stays there for 90 days, and you just switch it out every 90 days. And all of those are interchangeable. It's just whichever delivery method is preferable to the patient.
Are they all covered by insurance?
Every insurance is different, but the cream, yes, and the tablets for the most part.
What about Medicare? Same thing?
Cream and tablets, yeah. Mm-hmm.
Okay.
Yeah, the ring is still
Is the
expensive.
cream messy?
The cream is messy. People tend to not love the cream because it's pretty messy.
But you only really have to do it 2 to 3 times a week.
2 to 3, yeah.
It's not like you have to do it every night.
Yeah. Initially, you do it every night for 2 weeks to kind of prime the epithelium, and then, twice a week. So, and then on alternating days, I have patients use just hyaluronic acid suppositories just for extra moisture.
And the tablets are just an insertion, and it's also a couple times a week?
Yeah, exactly. Each one comes with its own applicator. You insert it, you throw it away.
What about those new age treatments? Do you go to a spa and you get vaginal rejuvenation?
And yoni steam?
Yes. So there are. Yeah, so there are energy-based devices. So there are radio frequency devices. There are CO2 lasers. And those are great for women who don't want to use vaginal estrogen, or they think they can't, or maybe they can't. And they do the same thing, as Jen was mentioning. They stimulate collagen and elastin, but they also increase blood vessels and blood flow. So they make the tissue more lubricated, more moist, more plump, and they increase nerve sensitivity. So they're really a fantastic adjunct, the combination of vaginal estrogen and either Thermiva or whichever one of those treatments is the ideal, I think, for patients. Really love that, right?
Right, yeah. But just as a note, insurance does not pay for any of those therapies. They are FDA approved and they are safe, obviously if they're done in the hands of a provider, but that's the one drawback to them is that they can be expensive, and you have to be consistent with them. Any kind of energy therapy, you have to keep going back. So you need, for Mona Lisa, you need to go every 6 weeks.
Well, you do three times initially, and then usually annually after that. But sometimes symptoms return.
So I have a couple of questions from the chat. So it sounds like what you said was you can either do these energy treatments or the vaginal estrogen, but they're both the same. The results are the same.
Yeah, the results are similar.
Okay, and then
But the results, I think with the energy-based devices, the results are you maybe get a little more of like a quick kickstart. The estrogen
opposed
takes
to-
a little
okay.
bit longer. I don't know.
If using Uvafem, estradiol, twice a week to cure vaginal pain, is that good?
So yeah, Uvafem is the tablet. It's Vagifem. It's the tablet insert twice a week is good. If your pain is from dryness, that's good. Pain can also be from muscles being too tight. Pain can be from, then you have to go see Lauren. Like pain can be from different things. But if the pain is from decreased lubrication, then I would use that in addition to a lube.
So if you were having pain and you used one of these suppositories, how long would you wait for that to work before you went to see Lauren?
3 months.
3 months.
Yes. It does not, estrogen does not work fast. It's a low dose of estrogen. You have to give it time. And if you don't give it time, then if you think it's not going to work in 2 or 3 weeks. Like you have to let the estrogen like build up in the system and rebuild the tissues, right?
Okay. And then is hyaluronic acid vaginal suppository over the counter or prescription only?
Over the counter.
And is that the same as the Uvafem that you just talked about?
Uvafem is estrogen, vaginal estrogen.
So that's prescription.
Yeah.
And what's the difference between the efficacy of both? Because you said sometimes you have patients do the hyaluronic
So
acid.
hyaluronic acid is like a moisturizer. It's just like putting a moisturizer on your skin. It's good upkeep. I tell patients to use that since you're only using the estrogen twice a week, I say to use the hyaluronic acid on the other days, just as a moisturizer when you're not using the hormone.
What type of patient, what do you look for in a patient to prescribe it? Like what are the indications to prescribe vaginal estrogen?
So the one thing about vaginal dryness is that it's a progressive condition. So, unlike hot flashes or other things that happen at menopause that are going to kind of get better with time, the vaginal dryness gets worse. So when we see a woman who's, in her 80s and never used estrogen, it is very dry. And if we were to give her estrogen, it probably wouldn't do the trick. So I think it's like a good preventive thing for every perimenopausal woman to be using vaginal estrogen.
And the definition of perimenopausal?
Anyone who's starting to have symptoms of decreased estrogen, which might be any woman who's in her 40s, let's say
Fatigue, sleep changes. You may not, get hot flashes.
Right.
Irregular
Right
periods.
away.
Headaches, irregular periods.
Loss of desire for sex. Like now sex is kind of like uncomfortable. So like those are things that are all of the, like the starting out.
Little gut. Weight's harder to lose.
Sometimes weight is harder to lose. You just don't feel like yourself. Brain fog. Like those are all kind of some of the signs of, and like I see lots of patients that are like, oh, I'm so fatigued. Maybe it's my thyroid. And I'm like, well, no, it's probably just you don't have any estrogen. Also, like, so I think you have to look for all the things, and you do want to do lab tests and make sure. And they also with hormone testing, patients always say, well, can you check my estrogen level? I'm like, well, I can, but it doesn't mean anything because I have no idea what your estrogen levels were when you were 20. So if they're any different than they are now, even if they're still in the normal range, you could have been way higher in your 20s and now you're feeling it. And men, the same thing with testosterone. So like it doesn't really matter the level of the hormone. I don't know if you practice that way too.
Yeah, absolutely. I go entirely based on symptoms.
Symptoms, yeah.
Plus, at perimenopause, you get these like spikes as it's on the way down. So yeah, I think it's completely meaningless, but patients really want it.
Like the hormone levels, yeah.
Well, I have a question for you. So what about testing testosterone levels? So can we talk about testosterone for women's libido, right? Like I know for premenopause, so we didn't really talk about it. For premenopausal women, there's a couple medications that are FDA approved, but for postmenopausal women, testosterone is not FDA approved, but it's really effective for libido. Is it something that you prescribe?
It is not something I prescribe. Normally, I'll tell them go see the urogynecologist or gynecologist or hormone specialist, and then I'll say, but in the meantime, why don't you try some low dose DHEA and see if that changes your clinical symptoms or like your desire.
Can you say what DHEA is compared to testosterone?
Yeah, so DHEA is sort of the precursor hormone that we have in our bodies that turns into testosterone and estrogen, but more so it usually gets converted to testosterone. So it's like the precursor hormone. So if you take the precursor hormone, your body will take that little hormone and it'll turn it into testosterone. Because testosterone is actually a controlled substance, meaning that like you really have to have like a good DEA, and we have to send it to like specific pharmacies for you to get it. Estrogen, on the other hand, is you can just give that willy-nilly anytime.
Right.
Does this affect women who have PCOS? Like, is it different, the way that you prescribe these therapies, or no?
Well, it depends on the age of the woman.
Oh, gotcha, never mind.
Mind the age. Yeah.
Yeah.
But I mean, there are very young women, I'm sure you've had this too, that we've given vaginal estrogen to because they have some dysfunction, like sexual dysfunction, and it does actually really help.
Yeah. For sure.
Like women in their 20s. So.
Okay,
But
so
also use lube. That's all.
lube.
Yeah.
Use lubricant.
Yeah.
There's the word of the night.
Yeah.
So testosterone, how can it be prescribed?
So it has to be compounded. So we can have it compounded into a cream or a gel, and the woman will apply it usually to her inner thigh nightly, a very small amount. But to Jen's point, it's a controlled substance. It's not without side effects, so it's important to do it with a trusted healthcare provider, follow labs, do not get pellets injected into your butt, because that is a 3-month, dose of testosterone. If you have side effects, if you start growing a beard, you start getting acne, you can't take that out of your body. So that's something to be cautious of.
Right. And there are drugs that if you're on, estrogen, testosterone, and progesterone. So I think the one thing that confuses women is if you're going to take a systemic estrogen, and you have a uterus, you also have to take progesterone. Yes. You have to take them together, or else you will just have bleeding, right? And then if you're going to take testosterone, if you're going to start testosterone, that's actually when the labs become more important, because you're going to watch what their levels go to. Men, it's the same thing. And I also don't care what men's levels are. I usually treat on their clinical symptoms, but I will watch that they don't get too high. Yeah.
Right. Yeah. Okay.
Same thing.
Mm-hmm.
Okay, one quick question, then I want to move on to a new topic, but increased risk of breast cancer with prolonged vaginal estrogen.
No.
Go ahead, say the whole sentence.
Okay. Vaginal estrogen is local only. It does not get absorbed into your bloodstream in any clinically meaningful amount. There is ample data showing this. There are lots of studies looking at the serum levels. There's an initial very little spike, and then it goes down to baseline, and so it does not increase risk of breast cancer in patients who are at risk. It does not increase risk of recurrence in patients who've had estrogen-sensitive breast cancer, so it is safe.
Right, and the other thing is that about estrogen, you've had estrogen in your body your entire life.
Yes.
If it was going to be a cancer-creating hormone, you would have started making cancers from the moment you had estrogen. So people who get cancer, that's because of a mutation that causes the cancer. Now, you can have a cancer that's estrogen sensitive. So the estrogen, if you were taking it systemically, not vaginally, could make a cancer worse. But it certainly does not create a cancer. So if you're getting your normal mammograms and you're getting your normal pap smears and all your normal follow-up, then taking hormones, whether systemic and especially vaginal, because it really doesn't act systemically, then it's not a big deal. It won't create cancer in your body. The cancer is going to come, whether the cancer is going to come. There's already a mutation and it's going to get started up. But taking the estrogen didn't make that cancer form.
Okay, so here's the next topic question, and we're going to start with Lauren, and you guys are each going to answer this one. So aging and sexual wellness, but I would kind of rather you talk about, like, what are the different age groups or one specific age group that you see issues with sexual wellness, and how do we deal with that? Because it's across the spectrum, right? So I'd like for whichever one you pick, Dr. Linehan has to pick a new age group, and Dr. Lane has to pick a new age group. So you get the first pick.
Okay. I would say I see people, if I see younger women who have pain with intercourse, unfortunately there's a relationship between history of sexual trauma and pelvic pain. Some of the studies on men's pelvic pain is if men who have like penile pain would be if they had a big life change recently, like a loss of job or like a recent divorce, stress. And I don't like to say, oh, it's just stress, like, oh, just relax, right? But it's in the research, there's a relationship between muscle tightness in the jaw, the neck, and the pelvic floor. It's like where people tend to clench. So I'll see people, or so if it's younger women, it's people who would like to have a speculum exam, but it hurts a lot. It's painful. Or people who they go to have sex for the first time and it's painful. Or I've also seen it in people who don't have sex until marriage and then they get married and then they have pain with sex. There's a link also between like religious trauma too and pelvic pain. So sometimes it can be like spontaneous and they don't know they have it until they go to try. So I love working with them. There's, the same way there's ways to like relax the jaw. It's kind of like you over clench your jaw and you don't know you're clenching it and you don't know how to unclench it, essentially, but it's the muscles of the vagina. So I teach people like how to relax those muscles from the inside out. So yeah, you could massage your jaw, right? But you also could teach yourself how to relax it from the inside out using like breathing and mindfulness and body awareness. And then, if you have a tight jaw, like there's some posture things you can do. So for the pelvic floor, it's like some yoga-based poses and things that open up the pelvis and connecting them with sex therapy and like telling them that like there's nothing wrong with you and your body perceives this as something. If your body perceives a threat, whether it's real or imagined, your muscles get tight. So like validating that for them and saying like, you might be worried about it, kind of like putting contact lenses in. Or if you ever put an eye drop in, like your eye wants to close, and then the more comfortable you get with putting eye drops in, the more comfortable your eye is staying open. So teaching them that like, you're not broken, there's nothing wrong with you, your body's a little scared of this, you can learn to desensitize it, you could desensitize the nerves. So that's one group I really enjoy working with, and I think you can really help them like unlock a part of their sexuality is part of our being. Children, we have sexual development from when we're in utero until adulthood. So I think it helps them like unlock a part of their being. So I really like that age bracket.
So before you go on, 2 questions. One, sex therapy. Mm-hmm. A lot of people have a lot of different ideas about it. So can you just say a couple sentences about that? Mm-hmm. And the second one is, in that age group of 20, 30, 40-year-olds, what percentage of them do sex therapy in addition to pelvic floor physical therapy?
Unfortunately, sex therapy isn't covered by insurance, so I think that's a barrier.
What is sex therapy, though?
So sex therapy. So they are trained therapists. You can be like an LPC, so a licensed professional counselor, an LMFT, a licensed marriage and family therapist. I always found that one, like a PhD. And so they do additional training. ASECT is the American Academy of Sex Educators, Counselors, and Therapists. And so they have programming that's designed to teach people. It's a few years, you have to do mentorship. And they specialize in sexual issues, so like libido or like a desire mismatch. Because if you think about, a lot of people go to therapy and you talk about issues that don't relate to the bedroom, and even in LMFT training where they work with couples, there's not a lot of comfort or question about what their sex life is like from a feelings-based approach. Like, do you feel safe? What would you like to communicate? Working on language to talk to your partner. If you have a history of sexual trauma, working with that, and then giving you interventions that are like suggestions that are like sex-based. For example, like the yes, no, maybe list, right? So they don't. It's more like the biopsychosocial, right? So the more like emotional and relational sides of intimacy that they diffuse with you, and then build interventions based on that.
Dr. Linehan, what percentage of patients do you send to sex therapy?
I say very, very few.
Okay.
it depends on in the male population, it's definitely less than I think with female that to sexual therapy, unless of course there's like cancer involved. Then a lot of patients that have had cancer, they do need to have some sex therapy because it puts a lot of like stress, the stress of not being functional because I had cancer and then I got treatment for cancer and that made my sex life dysfunctional. That group actually does have to often have sex therapy and relational therapy too, because there's some guilt around that for the patient that had the cancer, which is not right. But my favorite group of patients to treat are like the women who are 70 and over who are like, oh my gosh, Jen, I haven't had sex in 7 years and I found, a partner and now we want to start having sex. And like, what are you going to do to get them ready, right? Like it's the most encouraging. So you're going to do estrogen. You may actually want to do some like radiofrequency or ablative therapies, and they may need vaginal dilators and they may need to go see Lauren to help slowly open things back up again, especially if it's been a long time and they haven't had any estrogen. The vagina gets what we call atrophic or tight and dry, and it starts to kind of shrink down. So, and you don't want that. And that actually happens no matter what if you don't use vaginal estrogen. And so that's one of the reasons you actually should be using it, because it will shrink itself down.
So I'm just
Would
going
you
to,
tell those women to get, vibrator and increase blood
right.
flow with a vibrator before they take it out for a
Right.
spin with a partner?
Yes.
so there's a question which is in this, and I think you just answered this, but I'm just going to say it. Postmenopausal, 15 years. I use a low dose patch, which I'm assuming is estrogen. I'm interested in vaginal estrogen for thinning and pain. Would vaginal estrogen help these issues? And I think you just addressed that.
Yeah, definitely.
And maybe pelvic floor PT
To help
open
back up the vagina so that sex is not painful. Because especially if they haven't had any vaginal estrogen, like I said, the vagina is now shrunk down. You have to slowly give the estrogen and then open it back up and re-stimulate the blood flow.
Can you just explain what the dilators are for people who don't know?
So, there's lots of different types of dilators, I think, that are on the market that are out there. I don't know do you recommend a specific type?
Yeah, I have different ones. I would like to say caveat, I think there's a perception that like women, as they get older, everything just gets weaker. And like what Dr. Linehan said, it actually can be tighter. So a lot of people think, oh, I'm getting older, I need to do my Kegels. But in fact, like if you'd like to have sex and things are tighter, you actually want to do the opposite. So I think it's important to just like debunk that myth a little. There's different ones. I have ones. So Intimate Rose, there's certain companies that make them. They're like phallic shaped. So the first one, they're gradual. You can call them dilators or trainers. I think people hear dilator and they think it's gonna like stretch out their vagina and it'll never come back to the shape that it was, like gauging your ears. And so it's not that way. The vagina is lined with muscles, and muscles like contract and relax, so it's not gonna get stuck. So they start phallic shaped, so it's about the size of a pinky, and then this would be like size 1, and there tends to be like size 1 through 8, and so they gradually increase in size. Size 2 is kind of like a glue stick, and then it goes up to size 8. And so some patients, I like to prescribe them sequentially, so I'll say get a set, so you can start with number 1, and then work with that one, and then go to number 2. Other people can start a little bit, after an exam, I can guide them on which one they should start with. There are ones I like on Amazon that have like a little bit of a curve to them. So if there's like some deeper muscles that are tighter, I'll recommend ones that have a curve so that they can reach those muscles better and do some like selective stretching. So it just depends on their exam.
And can I add, are you guys familiar with the V-Fit? So there's a red light. It's more of a vibrator. It's large. It doesn't size up. But once they're sized up, there's this red light vibrator that I think is really amazing for blood flow.
Like red light therapy?
So what does the red light do?
The vagina.
What does the red light do?
Same thing as the other energy, just it's probably not as strong as radio frequency, but it also
Increases blood flow,
increases blood flow.
fluffiness of the tissues.
What's it called? The VFem?
V-Fit.
VFit?
Yeah.
Cool, I'll check it
Yeah,
out.
it's online.
For my
Doctor's
patient.
prescription?
No, you can buy it online.
Do they need the doctor's prescription for the
Insurance
trainers?
doesn't cover it, so.
No, they can just buy them online and you have a brand.
They've yes. They're not expensive. The ones I recommend online are like $50. The Intimate Rose, the sets are like $80 to $200 depending on how many you get and what size. I've had patients ask about if their HSA or FSA would cover it. I'm not sure. I've never
Maybe
done
if you wrote a
feedback.
prescription, it would.
Yeah, at one time they got FDA approved, so then they needed a prescription, and then it was a barrier because it was hard to get them, and so they took that requirement away. So now people can just buy them online.
Okay.
I didn't say my favorite.
Yeah.
Oh yeah,
Tell us your
go.
favorite.
Okay, so my favorite group, I think, is the cancer survivors, because I think there's so much survivor's guilt, and I think they're so afraid to even pursue enjoyment, and they feel like they should just happy to be alive and surviving. But there are so many issues surrounding sex and sexuality, and they might, however their body has changed, whether they've had radiation in the vagina and it just shuts it down, or the rectum. So there's a lot there to overcome as far as body image, and then, a lot of them might be not candidates for taking any hormones. So I just love educating them about what there is that we do have available to them. So that's fine.
And what's your team? Like, who are all of the specialists that someone who's had radiation of the vagina or radiation of the rectum or anus, like, who are the people that they need to see for sexual wellness?
Yeah, I mean, for sure, physical therapy, just couples therapy. Obviously, there's a lot to unpack there. And yeah.
How often do you recommend sex therapy?
Less than I would like to, because it's not as accessible as I wish it was. Yeah. And also, I think that when I do suggest it, I don't find that couples are, they're either like, well, again, I only see the women, and if they're in a hetero couple, they're like, no, my partner's not going to really want to.
Not going to do that.
Yeah. But I loved what you were saying. I mean, a lot of this, maybe they don't need to go see a therapist. All those, activities or tools, they can kind of do a lot of it on their own. But yeah, I think communication is such an important part of this whole picture that is just, we overlook it way too much.
And I think we always talk about this too. Culturally, especially women, we are taught not to talk about sex. Like, we're not to talk about pleasure with sex. Like, it's not something when you're a little girl. That's not what nice girls talk about, right? They don't talk about that kind of stuff. So I think that's also cultural for women as well, and why we tend to shy away from searching out pleasure.
Yeah.
Men will search out pleasure much more often than a woman will, sexually, right? And so, but then that is, I think, very cultural for us. So I feel like we have to talk to women as doctors, as therapists, as everyone, that this is okay. You should want these things. This is an important part of your relationship, and don't be afraid to figure out ways to make it better.
Yeah. And there are tools, there are things that we can offer. I think that's because it's not talked about, I think women don't even realize, everyone knows about Viagra, and then women think there's nothing that we'll be able to offer them, which just isn't the case.
Pills that you're talking about?
Well, so for premenopausal women, there's these pills, there's a prescription called Addyi that's FDA approved. It's expensive, and you have to take it consistently, but...
It's a horny pill?
Yes.
What?
It's a horny pill. Yes.
Everyone should know.
It's very clear what that is now.
For sure. But we can even get a similar result just with using Wellbutrin. Is just as good for desire as well. It's another horny pill. I'll say it.
How does that compare to estrogen or testosterone or those?
So estrogen.
How do you think about all of those hormones?
So when I think about estrogen as kind of restoring, maybe for when the woman comes in and is saying she's not feeling kind of like she was before, but I don't think of it as treating a decreased libido.
Okay.
So I will start with estrogen replacement if it's a perimenopausal woman who comes in and it's appropriate for her to take systemic estrogen and progesterone if she has a uterus. If that doesn't address the issue, then and it's none of the psychosocial things that we've talked about, and then I'll think about adding a prescription.
Would you do
for her.
Addy before testosterone?
Yeah, that was my question
I
too.
would do Wellbutrin or Addy. So testosterone has been more well studied in postmenopausal women than premenopausal women. So that's a little bit
For
of
sexual
my
desire or for
yes,
Okay.
for libido. So for libido, my decision tree is like premenopausal women. I think about Wellbutrin / Addy.
Wellbutrin is covered by insurance and Addy is
Exactly.
not.
Wellbutrin's been around forever. It's covered by insurance. We have long-term safety data on it. It's covered by insurance. So that's
Okay.
what I would give instead of the pink pill. Sorry, Addie. And then for postmenopausal women, with like very carefully, I would give testosterone. Also,
is Addy the only pill that's like that?
there's an FDA-approved injection, the bremelanotide, and it's like an injection you give yourself 45 minutes before sex, but it's not people don't really like it because A, you're giving yourself an injection, B, it causes a lot of nausea, so you might
really?
be throwing up while you're trying to have sex. So yeah, it's not really like, honestly, I've never used it. It's not very well liked.
What about there's a supplement line, Bonafide? No.
Yeah, so they
make
make
Reverie.
so
They make Reverie, which
Do
is
they make a
hyaluronic.
horny pill?
I don't know if they make a
No,
horny
they
pill.
make the
Supplement?
Reverie, which is the hyaluronic acid, the moisturizer. Oh, yeah, they probably make a supplement. Yes, you're right. They do.
So I don't have that much.
Yeah, I don't know.
experience with
There's not like, there's not much data on it. I mean, there's all sorts of things. Ashwagandha, I think, is good for libido. I'm not an expert
So
on
here's the thing.
supplements.
There's a whole bunch of different things out there that everyone can find on Google and
Yeah.
AI.
Yes.
So if someone's having sexual dysfunction
Yeah.
or just unhappy with where they are, where do they go?
Us.
Gynecologist, I think.
Gynecologist, urologist, urogynecologist.
Yeah.
And what?
And so I think also,
But should anyone start
go to
with you or
Instagram.
should they get referred to you?
I mean, here I need a referral. So, but direct access exists, and
But they should be seeing someone else so that they can address all these other issues.
right. But we're also
everyone
trained
should
to
refer to
identify
yeah.
if someone is, if it's like outsider scope or if they would need someone else. So need like another provider. But I would say both.
Yes.
Would be helpful. Another thing I'd like to say is like. Part of sex is like pleasure, and I think our culture has an absence of
All
like
of sex should be pleasure.
right, but part of it, well, and people also do it for pleasure, but also for romantic connection. Adults, it's how adults can play with one another, right? So, but I think like there's an absence of like enjoying like pleasure. So I think for my patients, I tell them like it's hard to not do things that you enjoy in your whole life, and then you get in the bedroom and you're like, okay, now I'm gonna enjoy being in my body. So I say like chocolate chip cookies are pleasure. Your favorite song in the car, pleasure. Doing a dance party by yourself, pleasure. Like I think we need. No, I'm seriously. I think if we get more used to experiencing like embodied pleasure and embodied joy, then we know. Okay, this is how it feels when I experience pleasure. I want that in the bedroom. So I think a good place to start is like find pleasure, embodied pleasure, a massage, right? You know, some people get acupuncture, you know, bake, whatever it is. But embodied pleasure, I think, is something that we can incorporate. Our bodies are wired to enjoy pleasure. So I think that's one thing. And then, yeah, my patients do nothing they enjoy, and then they're like, and my clitoris in the bedroom. And I'm like, well, you know, could you, yes, and, right? I want to say pleasure, and then, and the goal of sex doesn't have to be orgasm. I think there's this like desire for an orgasm, and we can like qualify if sex was good or not good based upon the number of orgasms or whatever. But Emily Nagoski also says like trying to chase an orgasm is like trying to chase a puppy to pet it. Like the harder you try, sometimes it can be like avoidant, but if you just experience like pleasure and you wait and you breathe and you're like present with your partner, that can come on more organically. So I think I'm like very pleasure forward in life and in the bedroom, and I'm not as like orgasm goal oriented. Let's quantify it based on that.
I totally agree with that. And
Last
I do
minute.
want to add
Last minute
that
on sexual wellness, and then Dr.
As-
Linehan gets the last minute.
for orgasms, I was going to ask her. I started prescribing compounded sildenafil cream, to rub on the clitoris to help with orgasms. What do you think about that?
I think that's great. I mean, anything that's going to enhance the blood flow.
What does this do?
So it's like Viagra in cream form that's
Oh.
compounded, and women can rub it on their clitoris and
Right.
help
So the
them
clitoris
with
and the
orgasms.
penis are the two synonymous structures, right? So in order for your women to help them reach an orgasm, but you can still have pleasure.
Which we don't need.
Yes, you don't need, but in orgasm, they're wonderful.
Right.
Both and, maybe.
Yeah. So if your clitoris should get engorged with blood, which increases the sensitivity and the nerves, and then that leads to, sexual pleasure and an orgasm. And then the man, it's the penis, gets engorged with blood and gets firm, and then the rubbing of the penis or sex or whatever, then reaches an orgasm. The enlargement of the clitoris and the penis and orgasm are two different nerves. So men will always ask me, and women don't know this either, a man doesn't have to get hard to have an orgasm. All he needs to have is the penis rubbed. So for men who don't have erections, they can actually still have sexual relations with their partners and still get an orgasm. So does that the same for women? I mean, I think yes. But, I mean, obviously some women it's clitoral stimulation. For some patients it's vaginal stimulation. So in your vagina, people always talk about the G spot. That is actually the base of your bladder. Okay, when the penis goes in and at the top of your vagina, that is the base of your bladder. It's incredibly sensitive. For some patients, it actually makes pain with sex because it's overly stimulated. And for some patients, they get more pleasure from having the lower portion of their vagina, which is where the rectum is stimulated, to become aroused. And actually men are the same way. Like some men actually do need rectal stimulation to become aroused, especially once they've had surgery for prostate cancer. So sexual pleasure is different for everybody, and you've got to find your own thing and do some deep diving. Also, do you have a book to recommend patients that you...
Come As You Are by Emily Nagoski. Come As You Are is for self, and then Come Together is the latest research on relationship longevity. If you have a long-term partner, how to keep it spicy. But it's all evidence-based. It's all evidence-based. Come As You Are and Come Together.
Do you have a book?
I don't.
Do you have a book? Okay, we're over time. Okay, last word about sexual wellness, anybody? I feel like keeping it spicy.
Pleasure, find out what feels good for you. Pleasure, find out what feels good for you. Yes, no, maybe list. Learn how to communicate it to your partner. Don't be... We have to change the tide, and we're only going to do it if we start. So talk about it.
Hormones and horny pills. The 2 H's.
I like it.
Hormones.
Hormones.
Ditto.
Thank you so much. Please let us know what other topics you want coming up. Stay tuned, and these will all be posted on the YouTube channel, so share with your friends. You did good.